Hey, warm welcome to today's video. Now, the subject I'm going to look at today is stimulated by an awful lot of emails I've been getting. People who are still getting features of COVID disease and tiredness and headaches and palpitations quite some time after they've recovered from the acute illness. So this is a bit of a review of long COVID, what are sometimes called long haulers. People that don't recover in the normal sort of 7 to 10 days that thankfully most people do who get the infection. Now, bottom line wise, I'm not sure there is one really. About 60,000 patients in the UK seem to have significant long COVID. So that would translate to probably well over 250,000 in the United States. Some of these recover after weeks, some after months. Others aren't recovered yet from infections way back in the first wave. So how long this is going to last, we don't know. Is there going to be a burden of morbidity here? And we're probably looking at about 5% of people who get COVID suffering some form of long COVID. Now, hopefully most of those are going to resolve after weeks and months, but some do seem to be persisting. And there's a very wide variation in the symptoms that people get. So that's probably the main part of the bottom line. Let's look at some details straight away. So this is Professor Paul Garner, who himself is an epidemiologist at the Liverpool School of Tropical Medicine. I did some training there myself a few years ago. Now, he's written up his experiences in the Lancet, which of course is a very good thing to do, quite a noble thing to share your suffering with other people. And he says this: I'm unable. So this is 95 days after the onset of symptoms. This is a long-term condition. That is a long time. He says, I'm unable to get out of bed for more than 3 hours at a stretch, just due to the extreme fatigue. My arms and legs are permanently fizzing as if infected with Szechuan peppercorns. Now, these are one of these things that are hard to understand. I have this very often. People will say, oh, it's like a heavy thing behind my eyes, or, you know, they struggle to put it into words, but Szechuan peppercorns are like the hottest chilies you can possibly imagine, and the idea that your arms and legs feel like that, it just sounds horrible. Sounds a bit neurological. I'm sure the professor's thought of that himself, but it just sounds really, really unpleasant, and I'm sure our thoughts go out to him already. He has ringing in his ears, tinnitus, intermittent brain fog, just can't think straight. Palpitations. Now, palpitations means you can feel your heart beating. So normally when your heart's beating, you're not aware of it. But then if it's beating more vigorously like that, you know, a larger stroke volume, more vigorous contractions, then you can start being aware of it. And you tend to be aware of it after exercise when your heart's going fast anyway, or if the heart rhythm is irregular is the other time, such as atrial fibrillation is when you can feel palpitations. Again, because it's to do with the heart, it's a very disconcerting sort of feature for patients, can be very anxiety provoking, really quite unpleasant, and dramatic mood swings. So really quite unpleasant psychiatric features there as well, psychiatric stroke, psychological features. So remarkably unpleasant sounding syndrome, and we do wish Professor Paul Garner well, of course. I'm sure you all do. Now, Centre for Disease Control in the States, I've checked their latest thinking on this, and it hasn't really moved very much forward. They do stress the need for more research, but let's see what they're saying. It is helpful. So many organs beside the lungs are affected in COVID-19. We know that. Heart and kidneys particularly. And we know that there's often gastrointestinal features, in fact, you know, the diarrhea, the vomiting, the upset stomachs and things like that, in the acute phase at least. Most patients recover to normal health, which is great. Some have symptoms that last for weeks or months. So some go on for weeks, some go on for months, and some have now gone on for many months. And the problem is that some of these symptoms that have gone on for quite a long period of time, it's looking like some of these symptoms are caused by actual organ damage in the minority of cases, thankfully, and they may not recover for a long time, indeed, if at all, it has to be said. Post-viral cardiac damage, for example, is a recognised cause of death. Certainly is. So some of symptoms that last for weeks and months after recovery from the acute illness. So this is different from the acute illness. So they get acutely ill, or this can be very mild, then they recover from that. This is the key thing, they recover from that. And then this sort of secondary syndrome comes along with a variety of possible presenting features. Long-term features can occur after mild and severe acute phase illness. So what CDC is saying here, it's not like the people that get sickest get the most severe long-term COVID. People can have mild disease and still be long haulers, still have this long-term problems. And studies are underway in the States, multi-year studies are underway. And of course they will need to be very longitudinal type of studies is what's going to be needed. So the CDC is actively working on these questions. How common is this? And it looks like it's about 5%, but depending on the duration. Who is most likely to suffer from this? And again, they're working this out, but there is provisional work that people that get a wide variety of symptoms early on may suffer from this, not necessarily severe symptoms, but there's a lot more to learn, so that they are actively researching that, so that's good. Do symptoms eventually resolve? Well, time will tell, won't it? This is why these are longitudinal studies. Now, CDC is very helpful here. Most commonly reported long-term symptoms are just extreme fatigue and ongoing shortness of breath are common features reported by the Centers for Disease Control, collecting data from all over the States. Next after that is cough, joint pain, chest pain. Again, very disconcerting features, chest pain especially. So the most common there is fatigue. Fatigue seems to be the main one. Shortness of breath, but then followed by these. Not the main one, the most commonly encountered. Now, other reported signs of long-term COVID: difficulty with thinking and concentrating, this so-called brain fog, depression, muscle pain, headache, fever that seems to come and go. Intermittent fever seems to be a feature, and this is strange because this is after the virus has been cleared from the body. There's still intermittent fever, so that is strange. And then fast beating or pounding heart, the palpitations, also reported. More serious long-term complications, less common thankfully, and these are the ones that might be caused by actual organ damage. So cardiovascular, inflammation of the heart muscle, that can cause damage of the heart muscle. Lung function abnormalities where the air's simply not getting in and out properly. And renal, which can lead to acute kidney injury where the kidneys just don't work. Basically what we used to call acute renal failure. Patients will produce not enough urine or too dilute volumes of urine to clear away the metabolic waste products that the body generates normally. Skin rashes, hair loss seems to be a feature that's not infrequently reported. Neurological problems, smell and taste might not come back. Sleep issues, difficulty with concentration, memory problems. Psychiatric, depression, anxiety, mood changes. And the CDC, well, at the end of their article, they say the best way to avoid these is not to get COVID in the first place. And then they give the advice that we all know about not getting COVID in the first place. So I think it's fair to say very incomplete article there from the Centers for Disease Control, but that's the only one I could find on their site, so that is basically the latest thinking. And of course the thing about the Centers for Disease Control is they don't put things on till they're pretty sure, so that is the reassuring thing about it. And I guess it shows the other features like or the other characteristics like the number of people affected and for how long they're simply unsure about. The data is not being collected in the United States. NHS response to this. Now this is new, 15th of November. They're launching a network of more than 40 pioneering long COVID clinics all over the country. So the NHS are taking this seriously to help thousands of patients suffering debilitating effects of the virus months after being infected, and more than 60,000 people in the UK at the moment. So this is pretty large numbers of people that seem to be affected by really quite significant long COVID features in the UK. And they mentioned some things it can cause. Now, the criteria for going to the clinics, the patients will have been hospitalised or officially diagnosed with an antigen test or reasonably believe that they've had COVID-19. So some of the people I've been talking to about this actually got their clinical features way back in like March, April, where there wasn't the testing available. So they had the features that indicate they had COVID, but not known for sure. So if there's a clinical judgment, this was caused by COVID. Usually referred by a GP, but could be other healthcare professional referring them to these clinics. And these clinics are going to be multidisciplinary in nature. So we would expect nurses, doctors, perhaps infectious disease doctors that specialise in chronic fatigue syndrome, for example, as well as other things like biochemists and other useful people that we need to do the tests. And indeed, we would expect psychological, psychiatric input as well. NHS Chief Executive Sir Simon Stevens. Long COVID is already having a very serious impact on many people's lives and could well go on to affect hundreds of thousands. Now, I don't like the sound of that. This could be... We don't want to be scaremongering here, but there's two things that we're worried about. There's the acute illness where the health services can be overwhelmed, and people will die unnecessarily, and it's bad to get ill even if it's just for a few days. But what's concerning is we could be left with a long-term morbidity burden as a result of this disease. Potentially large numbers of people that have difficulty returning to normal duties, work and things like that. We don't know yet, but the boss of the NHS is concerned about, and that's a direct quote, that potentially hundreds of thousands. That is concerning, and all the more reason why we have to be really stringent on trying to prevent the spread of COVID-19 while we wait for the vaccines. So clinics will help address very real problems being faced by patients today. So that's for the individuals themselves. And then the NHS is also setting up a task force to look at this as a whole. Greater understanding of the condition, and basically just to get a handle on what's going on here. What is happening. Now, they're suggesting that there's different ways, there's different groupings. So different people are looking at this and coming up with different ways to classify symptoms. Because people that write up clinical symptoms, they always want to classify them. They want a box for that group and a box for that group and a box for that group. To be fair, it doesn't always work. Chronic fatigue syndrome is one of the classic ones actually where it doesn't work very well and people can end up suffering without an official diagnostic category. But nevertheless, this is what they're thinking at the moment. Post-intensive care syndrome. This is fairly well recognised already, of course, people that have been to intensive care. This is the more severe people. That they get impairment of physical function. They can't. They have physical problems. I mean, it could be residual renal problems. It could be residual breathing problems. It could be lack of fitness. But they also get cognitive problems, difficulty concentrating. And of course, it's a very traumatising thing to go to an intensive care unit. So there can be psychiatric problems as well. And I've certainly talked to people who have psychiatric difficulties many years after an episode in intensive care. Post-viral fatigue syndrome is a category already known, so it could be that a lot of COVID patients kind of fit into that category. Permanent organ damage could be anything, depending on the organ that's involved, and that may well be irreversible if the organ damage is severe. And talking about a separate category called long-term COVID syndrome. So that's kind of the classification the NHS is looking at the moment. But this is very much developing. But they will be collecting prospective data from these clinics. So the knowledge on this should really increase quite substantially. And these clinics should be starting, basically they're starting about now, late November, early December. Now, Journal of the American Medical Association. It's a very moving account, actually. Dr. Jeffrey Singelman wrote the article. On Monday morning, he woke up with a headache, then a fever. Next day, he had complete loss of taste. So he knew he had it and was confirmed by testing. So an acute illness. Now, the next category in his article is mild illness can have dramatic effects. Now, Dr. Singelman had no pre-existing conditions. We don't know his age, but we know he was fit. And during the course of his COVID illness, he was never hospitalised. So he had what would normally be classified as a mild course of COVID-19. He had minimal respiratory symptoms, and he even kept doing some work through the acute phase of the illness. So pretty mild week or so of symptoms that Dr. Singelman suffered. And but the problem is he didn't seem to recover. So 3 months later, the condition is like this. Fatigue has kept him couch-bound. Low-grade intermittent fever continues. And he had to self-isolate for 40 days. Now, the thing with the fever, after he recovered from the acute episode, he kept getting episodes of fever. And of course, we're told to self-isolate until 24, 48 hours after the fever has resolved. But he was still getting fever, so he kept self-isolating for 40 days. No direct contact with his family. Difficult for him, difficult for his family, of course. And the guidelines from the CDC and other international guidelines don't really seem to account for this, because they kind of assume that if you're still getting fever, you're still infected. But in this case, he wasn't. He did seem to have eliminated the virus normally. So clarification needed there from the governing bodies, but he rightly self-isolated for 40 days. Lack of objective does not preclude illness. Now, being a doctor is actually an acute care doctor. He likes to collect data and work out what's going out, but his tests started coming back normal. So he didn't have the virus anymore. His chest x-ray was normal, the imaging. The lab results were coming back normal. His oxygen saturations were normal. So some people are going to get abnormal clinical features that you can measure with a laboratory test, that you can hear with a stethoscope, that you can see on an x-ray. But he didn't. He didn't get that. But he says, I did not feel fine and I still do not, despite these being apparently normal. And of course, this is always difficult in healthcare because people feel if there's nothing objective to kind of back up their story, they feel like they could almost feel like they're malingering, but clearly in this case he's not. And I've known many people like this. The tests pan out normal, but the person is still tired. Well, the person still has pain. But there's nothing you can pin it to in terms of x-ray, in terms of physical examination, in terms of laboratory tests, even in terms of biopsies and things like that. You still can't actually pin it to anything. This is one of the limitations of modern medicine. So he didn't feel good even though these were checking out. He had a rotating constellation of symptoms, different each day, and his were worse in the evening. Now, I haven't heard this before, so it'd be interesting to see if this pans out as a common feature. Features were worse in the evening. So he woke up feeling better and then got progressively worse as the day went on. Fever, headaches, dizziness, palpitations, tachycardia, other features, all very unpleasant clinical features that he's still suffering from 3 months later. So he said, listen to the patient first, even in the absence of conclusive testing. Believe what the patient is telling you. It's like when I taught about patients in pain. I can't remember who said it now. McCaffrey, I think. We always said pain is what the patient says it is, existing when they say it does. So I would much rather, if I had two patients and one who was lying about the pain and one who wasn't, but neither of them had clinical features, I'd much rather give them both strong analgesics rather than miss the one who was genuinely in pain. Leaving a patient in pain is not acceptable. His loss of taste continued. He would feel his heart pounding uncontrollably for hours. It sounds absolutely horrible, Doctor. I'm so I'm sure people are feeling for you as we speak. It sounds horrible. I would get so dizzy that I could not even write a simple letter. And remember, this is months later. So what is going to happen? Is he going to get better? Is he going to stay like this? He simply doesn't know, which is a pretty horrible place to be in. The reassuring thing is that people do seem to get better. Some get better after weeks, some get better after months. But there's a group where we simply, like this case, where we simply don't know. So there we are. So that's all I wanted to say about long COVID. That's kind of where the state of knowledge is at the moment. I was going to do some other things now, but I think we've probably done enough for today. I'll just show you one thing. It seems like, at long last, the message is getting through about ventilation. Take care, refresh your air from the National Health Service. It's only taken 10 months, so I suppose we should be grateful for small mercies. But it's getting through. I had to go into a shop today, and was associated with a local supermarket, and I was talking to the ladies in the checkout, and there was like a supervisor there. I think he was a supervisor, and I said the ventilation in here is not that good, you know. And he said, what? You know, he wasn't really paying attention. I said the ventilation. I said the key thing is the viral load. You need to reduce the viral load with good ventilation. And he went, oh, and then went off and did something else. You know, it was actually quite impolite. He certainly didn't take on board what I said. You know, in fact, he didn't even listen to what I said. Now, having said that, the ventilation might be superb, going through all sorts of clever clogs filters. I don't know, but to me, it felt stuffy. So there you go. We're still not getting the ventilation right, unfortunately. Okay, and I was looking at the wrong camera for most of that time. It does get very confusing. I'm looking at the right one now. Okay, right. Thank you for watching this video, as always. Always great to have you.